Hello everybody, and welcome to this webinar on substance use problems in veteran and military populations. And let me start with an apology for the late start. Unfortunately, we had a few technical problems at the very last minute, but I've been assured they're all resolved now and the rest of the night will go perfectly smoothly, I'm sure. A warm welcome to all our participants across Australia. The last time I heard we had just over 700 people logged in tonight, so that's a very impressive number, and I think it probably speaks to just what an important issue this is when we're working with veteran and military populations. Welcome also to those of you who are listening to it or watching it later on a video or a podcast, and of course a very, very warm welcome to our panelists. Before we start, I'd like to acknowledge the traditional custodians of the lands across Australia on which our panel and our participants are located. I'd like to pay our respects to their elders, past, present and future, for the memories, the traditions, the culture and the hopes of Indigenous Australia. My name's Mark Creamer. I'm a clinical psychologist. I've got a loose attachment with the University of Melbourne, and I'm also in private practice. And I've had a very long interest for over 30 years in the mental health effects of trauma, with particular reference to veteran and military populations. And as a clinician working with that group, I find repeatedly, as I'm sure you all do, the need to address substance use issues. And so I'm extremely pleased to be able to facilitate this panel tonight and to be able to join you along with such a distinguished group of colleagues. So without further ado, let me introduce the panel. And you've all received the lengthy bios, so I won't repeat them in any great detail. But briefly, let me first of all introduce Dr. Matthew Frye. Matthew is a GP and an addiction medicine specialist, and among his many other roles, he is Clinical Director of Treatment Services at Turning Point Drug and Alcohol Centre. Welcome, Matthew.
Hi.
Good to have you. Thanks for joining us. You've been working in the area for a long time now, and I'm just wondering whether over those years you've noticed any significant differences in terms of the kinds of people who are presenting with drug and alcohol problems or the kinds of drugs that are being used?
Well, I think that's the beauty of the sector of the field. It never stays the same. It's constantly changing. So I've been working in the field for about 15 years or so, and I couldn't say any 2-year period was the same as the previous 2 years. It's a constant state of change. I mean, there's so many new things happening in drug and alcohol. The ages of people and the type of people that present have changed. The clinical pictures that people present with have changed, and the drugs people use have changed. So it's an incredibly dynamic culture.
Great, and presumably then keeps you on your toes, I imagine. But hopefully we'll pick up on some of those issues later tonight. Can I just ask you the obvious question, Matthew, and that is, how's your alcohol use?
Well, I don't like to say it, but I'm actually a teetotaler, and I don't say that because people think that those clinicians working in the drug and alcohol sector are the fun police. But I'm only a teetotaler because I've found alcohol isn't particularly rewarding for me.
Right.
I don't mind if other people drink.
Good, good. I'm very pleased to hear that, Matthew. Okay, well, thank you very much. We'll come back to you in just a minute. Our next panelist is Professor Nicole Lee. Nicole is a clinical psychologist, and one of her many roles is as a professor in the National Drug Research Institute. And she has a particular interest in the translation of research findings into policy and practice. So welcome, Nicole. Thanks for joining us tonight.
Thanks, Mark, and hi, everyone.
You're, among your many other roles, Nicole, I know that you're an advisor to DVA and also to VVCS. From your experience, do you think that there's any significant differences in substance use problems between the civilian population and the veteran military population?
That's a good question. My short answer is probably no, but we don't have very good data in the defence population or the veterans population, not as good as the general population anyway. But my my no answer is probably because I think there's multiple reasons why people use drugs and multiple pathways to developing drugs, and there's reasonably consistent sets of risk factors and protective factors that impact both on use and problem. So if there's any difference in defence personnel or veterans, it would be in their exposure to risk and the risk factors and the protective factors, so things like trauma and that kind of thing, which might be higher than the general population. But when you look at the data that we do have, which is a little scant, it doesn't seem like the rate of use for the same demographic is much higher. It is elevated, but it's not a lot higher than the general population.
Okay. And we'll certainly come back to those risk factors later tonight, because I think they're very important for this population. We better move on, but can I ask you the same question that I asked Matthew, if it's not being too personal? How's your alcohol use?
Well, I get asked this question a lot because, as Matthew said, it kind of does, people make assumptions about you, whether you use or not when you're in the drug and alcohol sector. And usually people ask me this in relation to illicit drugs because that's way more interesting than drinking. And I think because people look at me and I'm very tidy because I'm a psychologist and a Virgo, so that's a like double whammy for anal retentiveness. And they look at my title and my qualifications and they assume I don't drink or take drugs or use drugs now or have ever tried drugs. And I think that is quite important. I think that tonight I'd like to just invite everybody to think about their own assumptions and their prejudices about people who use drugs and what a drug user looks like or an alcohol abuser looks like. But I can tell you that someone did call me a straighty 180 the other day, so that probably gives you some idea.
Yes, okay. Well, thank you very much for that. Some very important points there, actually, that I think we'll undoubtedly come back to. Our final panel member tonight is Dr. Jonathan Lane. John is a psychiatrist from Hobart with a particular interest in veteran and military mental health and substance use in that population. And John has been in the Australian Army for 27 years, both as a regular and as a reservist. So he certainly knows what he's talking about with that population. Welcome, John. Thanks for coming.
Thank you very much for having me.
I was going to ask, John, we hear a lot about alcohol problems in the veteran population, but I'm interested in currently serving personnel. I guess that their opportunities for substance abuse are somewhat less, but is there much of a problem among active duty personnel?
Not really, no. There's a lot of occupational safeguards in place, and so active drug and alcohol testing for a start for everyone who's in the military, and so that's random drug testing that happens on a regular basis for people. On deployment, on operations, for example, every exercise is dry. So, overseas on active duty, definitely dry, but even, when you're on exercise within Australia, they're all dry as well too. Defence, over the last sort of 20 years, has had a good, long, hard look at the culture of alcohol use and abuse and misuse that's been, a big part of it, and certainly dialed everything way back. So you just have to excuse the guest wandering past there. But yeah, so alcohol, alcohol abuse is not tolerated, full stop, is probably the best way to put it. So yeah, moderation is fine, but compromising your performance and putting your mates at risk, it certainly is not. So yeah, that's probably the best way to put it.
Excellent, and we might talk a bit later about those changes and how that's changed over time. But I did it to the other two, so I've got to do it to you, John. What about your alcohol use?
So this is what I tell all my patients, and my rule of thumb goes back to another old army saying, which is, back in the day when you used to be able to drink when you went on exercises and those sorts of things, it'd be 2 beers per man per day perhaps. And so, when you're out bush or doing whatever else, you could have up to 2 drinks per person per day if you actually had access to alcohol. So this is what I say to everyone. So I had a beer this evening, not ashamed to say that, and I certainly tell all of my guys as well too, feel free to drink, not going to say you can't drink unless it's completely dangerous for you, but, otherwise moderation. So, 2 standard drinks a day with at least 2 alcohol-free days a week. So this is what I say to people. So, and again, when you put it into terms of, 2 beers per man per day, perhaps, then most people get that pretty quick.
Yeah, that's a good message, actually, isn't it? Good message, yeah. Yeah. And moderation, I agree. Moderation in all things, including moderation, perhaps. I'm not sure. Okay, thank you very much for that and for your self-disclosures there. I mean, if I was honest, I should tell you mine as well. So I would hate to have been asked this question 30 years ago, I must say. But at the moment, I can be reasonably smug. I don't drink anything Monday to Thursday, and I do kind of make up for it a little bit Friday and Saturday, but still, overall, it's within limits. Good. Okay, thank you very much. Thanks to all the panel there. Let me just go on and tell you just very quickly about this webinar series. This is the 4th in a series of 6 DVA commissioned webinars on veteran and military mental health. So the first was on the veteran and military culture, the second was on PTSD, the third was on sleep. And if you missed those, they're available as videos and or podcasts from the DVA At Ease website, which is a great website, and I think on the bottom of your screen there's a tab there that'll take you to it. But it's a great website, and you can get them there, or you can get them from the MHPN, the Mental Health Professional Network website. So they're available. Tonight we're talking about substance use, and then the next one is on anger, and the final one I think is on the impact on family. Now, I will just talk very quickly because we've got a new platform, and those of you who have been with us for previous webinars might notice some differences. I don't want to spend any time on it really. It's very straightforward. I don't think it's anything that's going to concern you. The difference perhaps is the chat box. So that's on the bottom right of your screen. You have to open the chat tab if you want to be part of the chat, and you can leave that open. You can move that little box around and put it in the right kind of place if you want. So you can use that. You've got the resource tab at the bottom right as well. You've now got a technical support button at the top of your screens, and so if you get stuck, there's some FAQs there, but there's also a number to ring. And we'd be very interested when you do your feedback at the end about what you thought about the new platform and whether it worked okay for you. Okay, now I'm hopeful that you've all had an opportunity to read the case that we circulated about Chris. Chris is a veteran. I guess this is not an unusual kind of story. Chris represents a sort of amalgam of the cases that many of us have seen over the years. And we're going to use Chris or Chris's case as a kind of platform, a sort of springboard from which we can explore a whole range of issues around substance use in veterans. We can look at the challenges and the pitfalls and what works and what doesn't and so on. And I would say that although Chris is a veteran, pretty much everything we say tonight is equally applicable to other similar populations, particularly those with PTSD and particularly groups like emergency services and so on. So in terms of the learning outcomes, as we say, we're going to use Chris's case as a bit of a jumping off point to get a better understanding of the phenomenology and the epidemiology of substance use disorders in veteran military populations. We're going to find out more about evidence-based treatments and what works. And of course, after that, hopefully we'll all have some increased confidence in actually working with these people with veteran and military populations and substance use disorders. In terms of the format for tonight, I'm going to ask each of the panelists to give a brief chat about their perspective on Chris's case. So they'll talk each for about 5 minutes and run through a few slides to give us their perspective. And then we'll open it up and have a broad discussion based on the questions that you've sent in and are sending in tonight about some of the issues raised. So without further ado, let me hand over to our first panelist, Matthew Frye, to talk about his reactions to Chris's case. Over to you, Matthew.
So, thanks, Mark. Look, when I looked at this case, I was asked to put together some thoughts about what the key issues for me and are, and as an addiction specialist, I listed a few things, and I sort of looked at them chronologically, and I think the first thing that stands out about case is that he's got this significant family history, and we often talk about this. And perhaps it's not a great, huge clinical significance because maybe things wouldn't have been done any different in his life regardless of family history. I think it's still, very important in drug and alcohol that we look at family background. Then the other thing about family background was how he grew up in his relationship with alcohol, what happened with drinking in his household, with his parents. And then, as we know, he moved into the armed forces, into the Navy. And what I thought about that in seeing some service people is that that's a very structured environment. As John was mentioning, it's quite strict often, and it often seems to bring some really positive qualities around structure to people. But then he started to migrate into drug use. I've mentioned that I really, whenever we discuss illicit drugs alongside alcohol, and I mentioned reward in the initial question about alcohol to me, I mean, I think we've got to look at why people use drugs, and I just really put that there as a general statement about what we need to keep in mind is, and especially with a lot of discussion popular media about methamphetamine, is that these drugs, people like these drugs. There are benefits for people from taking drugs. They don't start out taking drugs wanting to end up seeing somebody like me in drug and alcohol treatment. They often do it because of the setting that they're growing up in, the culture, and what their peers are doing. And it's often very important part of people, particularly in these generations that we're living in, a very important part of people growing up. Look, finally, I think the interesting thing about Chris is he's a very interesting archetype in that his condition progressed. He's a really good demonstration of what we see all the time, and this is the big challenge of drug and alcohol, I think, particularly for clinicians, is that we're dealing with people who don't necessarily have the same view about their substance use as we might have, and they're often very hesitant or ambivalent about what they want to get out of treatment, what they want to do about their substance use. And I say I don't find that a challenge. That's bread and butter, but I do think in talking to colleagues and peers, they from, if you like, mainstream or conventional parts of the health sector, they find that really difficult that people can present for treatment, really unsure whether they want treatment. And the other thing I'll mention here is the value of the coercion in his case, and this is really incredibly controversial about how effective is treatment that people are kind of compelled into. In this case, his father, I think, has sort of laid down some conditions about treatment, and the general consensus has been, if somebody doesn't want to go into treatment, we shouldn't be compelling them. But look, I've worked in the treatment of healthcare professionals, and many people might have worked in the management of people whose job or child support depends on how they progress in treatment. And look, sometimes coercion can be really quite effective, I think, and I know you're going to agree with this. But I think sometimes a push where there's something at the end of your response to treatment is actually quite helpful. So look, that's what I wanted to say. I imagine we'll get some feedback on that, but thank you, Mark.
Yeah, great. Thank you very much, Matthew. And I am very interested in those comments that you're making at the end there about the ambivalence and the coercion, and I'd like to start the general discussion when we get to it. Sorry, maybe with those kind of points about how people get into treatment and what are the kind of things, what are the nudges and so on. So let's hold that point in our heads, and we'll come back to that later. Let's move on now to a clinical psychology perspective and a bit of research perspective as well. Hand over to Nicole. Nicole, over to you.
Okay. I've kind of not talked, I don't want to talk too much about Chris himself, but just flag a few things that we need to think about. I think that we can sometimes focus a bit too much on use over harm. So I'd just like us to kind of tonight redirect our thinking a little more towards the impact of alcohol and drug use on a person, which helps us to focus on the actual problem. It's not so much a problem that he's using drugs, but the problem is that he's starting to have problems with them. And so just on this this kind of timeline, I've flagged potentially where those things go. Just to demonstrate that a bit more, this is just data from, don't worry too much about it, it's data from the National Drug Strategy Household Survey, and you can see that illicit drug use in the general population is relatively low, and it looks pretty much like that in the military population as well. But if you look at my specialist area of methamphetamine, there's not been, you can see the lines of all of them are pretty flat or coming down, and in methamphetamine there's not been any increase in meth use since about 1998. But we've seen huge increases in harm. So if we focus just on use rather than on harm, we're going to miss a big part of the story. And equally, if we focus too much on dependence and assume that everyone who uses needs treatment because they're dependent, we're also going to miss a large group of people who will be having problems other than dependence. So this data here is just broken up by frequency, which, by the way, tends to be more commonly associated with problems than quantity. So we generally do it's really important to ask about frequency of use. The red numbers are where we think the percentage of the people who use these drugs are at risk of dependence. And that's relatively small, as you can see, between 5 and 15% for any given drug. And then there's a bunch of people in the middle who are putting themselves at risk of harm that don't get captured if we just focus on dependence. So at both ends, we need to kind of bring that in the middle and think about harms over use, and dependence is potentially one of those harms. So I just encourage you to kind of shift your thinking in favour of harms, and just while we're talking tonight. So the other thing about Chris is that he's showing some reasonably significant mental health problems.
Is that the slide you want? Yeah.
No, my slides are all. I've got the right slide with this graph here. So this is just a study we did with ICE users a few years ago. We asked ICE users in treatment about the history of use and dependence and treatment, and I'll let you read the details of it later, but you can see the red line is people who didn't receive any mental health treatment, and the blue line is people who did receive mental health treatment. And you can see
Sorry, Nicole, can I just interrupt a second? We seem to be having a little problem with your slides, so they keep jumping back, but this is the one you want. Shall I change them from here, do you think, or is someone else playing with them?
Yeah, if it's helpful for you to change them, I'm happy for you to do that. I want the one that says no mental health treatment. So it's forward from the one I can see now that says use versus harm.
No, the one I can see is the graph.
Okay, I can't see that. Sorry, there's another technical issue. So.
Oh, okay. So we're looking at we are looking at the graph that says no mental health treatment. Yeah.
Great. Okay, I'll let you change them then.
Okay.
The point of this is that you can see that people who didn't get mental health treatment took twice as long to come into drug treatment than people who did receive mental health treatment first. And there's a whole range of reasons, nuanced reasons why that might be that I won't go into. But I think I wanted to show you that to make the point that whatever doorstep the client lands on, that's what they think their problem is, and that's the thing to deal with. So if they go to their GP asking for sleep help, then if you do something, it's better than doing nothing, even if you don't think it's the main problem for them. So in the next slide, just what works in treatment, I just wanted to emphasise that it's a bit of a fallacy among different people that drug treatment isn't that effective. And it's just as effective as most other mental health, chronic mental health conditions and most other chronic physical health conditions. And we look at the data from outcomes from treatment. Most of the treatment options, the mainstream treatment options for drug use problems, and I'm including alcohol in that, are effective, from brief intervention to CBT to long-term residential rehab. So the point there is to, again, do something, whatever you're familiar with. What doesn't work in treatment tend to be confrontational approaches, and I do agree with Matt that sometimes, I don't want to say coerced treatment, but incentivised treatment it can be effective. But confrontational approaches tend not to work. Those TV-style interventions, I don't know whether anyone's seen those, where the family all gets together and tells the person how awful they've been. Those things don't work. And boot camp style interventions tend to have quite a high dropout. And non-CBT interventions haven't really been well tested for drug use problems. So most of the things that we know work are cognitive therapy, dialectical behaviour therapy, ACT, most of them and mindfulness-based cognitive therapy and relapse prevention. They're all CBT-style interventions. And I guess my last point really is just that the most common outcome from treatment is actually relapse, which sounds very dismal, and someone told me I was being very pessimistic the other day when I said this. But the reality is that getting off drugs is relatively easy for most people. When people go into treatment, about 2/3 of them successfully completed, but staying off is much harder. So when they leave treatment, the relapse rate is really high. And the relapse from all types of treatment is about the same. So it doesn't matter whether someone's got a brief intervention or a long-term residential rehab, they relapse at around about the same rate. So everything works and everybody relapses at the same rate. So the important thing is that post-treatment period, we can't just kind of throw a bit of treatment at someone and hope that they'll be fine forever. We need to kind of follow up and maybe call them or check in every now and then, bring them back in for booster sessions if they need it, rather than waiting till they relapse before they come into treatment again. And that's
Great.
all I say.
Thanks very much indeed, Nicole. I'm reminded, I think it wasn't Mark Twain who said something like, giving up smoking's easy, I've done it 100 times. I mean,
Yeah.
So I can understand what you're saying there. Thank you very much, Nicole. Let's move on now to our third panellist and get a psychiatry perspective on this one. Over to you, John.
Great, thank you very much, Mark. Just confirming that the slide you've got up is the importance of role and purpose.
It is, exactly, yep.
Yeah, good, because my slides were lagging behind as well. Cool. So, look, thank you both to Matthew and Nicole, because the points there were incredibly relevant as well too. And I'd have to admit, you know, similar opinions on coercive treatment, if that's what you want to call it. It can be effective for some people for specific purposes. And going back to that point earlier about, you know, drug testing within the military and you know, the performance standards required to be in the military, that's a reason when you can use that, I suppose, as extra support, you know, for maintenance of abstinence or just control of drinking in general. Because, you know, with the military culture, the role sort of that a person has generally tends to be fundamentally a huge part of their actually identity. And so, you know, in this particular case, the guy was, you know, a stoker in the Navy, and, you know, people will ask him what he does, and he's a stoker. He works in the engine room, you know, he's a marine technician or a marine engineer or whatever else, but amongst his mates, he's a stoker. And so those sort of particular military values that our patient grew up with, and that, you know, most people will see that veterans have, one of the biggest problems that they have when they leave the military is trying to regain that sense of identity in terms of who they are and what they stand for. And this is where sort of people get lost without that supportive environment around them. The next thing to sort of talk about is that concept of social connectedness, because again, you know, Anzac Day is coming up, and with Anzac Day, we tend to think about the things you do for your mates. And again, within that military culture, you know, people rely on their colleagues, on their mates. You know, there's quite a clear hierarchical structure within the Defence Force, you know, within the military. Everyone has a role, everyone has a purpose, and everyone has a place. And so, again, what tends to sort of make life very difficult for people is when they lose that structure. And the case here is, again, a classic one of it, because, you know, he decides to get out, loses his friends, loses his role, and then starts to drink more, you know, gamble, do various other sorts of things because he's got no real purpose there. And what I often sort of say to my patients when they're talking about, you know, these sorts of things and the problems that they're having is whether they're using drugs or alcohol or whatever else as a coping mechanism or as a form of recreation. And, you know, too often the story is that people, you know, use alcohol to sleep, use alcohol for tinnitus, use alcohol to manage various other sorts of things in their life, or other drugs as well too. And so it's not just that the dependence sort of stuff that's going on, it's the coping because they're distressed, because they don't have that role, they don't have that sense of purpose, and they don't have that social connectedness in their lives. And so, you know, again, a meaningless life from their perspective, or a pointless life with no one else to share it with. And what else are they going to do but drink or use drugs or do whatever else? So, yeah, just wanted to very quickly touch on, you know, the importance of pharmaceutical support. Again, when people are going to stop drinking, thiamine, multivitamins, fundamental. You know, do not pass go unless you've had those. So, and the next things, you know, in terms of medications that we'd be using for someone like him, they are not, you know, as Nicole said, relapse is the most common outcome. So any form of medication that we'd use for someone like that, it's supportive, it's not curative. So the next question, again, as Nicole was talking about too, in terms of mental health, is there depression or anxiety or something else going on in the background as well too? Because if we don't address those sorts of issues and we don't treat those sorts of things, then we don't really have much of a hope of dealing with his substance abuse as well. So yeah, thank you very much.
Brilliant. Thank you very much indeed, John. And yeah, you've raised a whole range of issues there that I think we will definitely come back to in our discussion, which we're going to go into now. So we'll open it up and have a broad discussion, and I would encourage our panelists to just jump in at any time that they would like to, and certainly to feel free to disagree with each other if the need arises. I've been very impressed with the number and the quality of the questions that you as our participants have sent in the lead up to the webinar. And I would love to be able to go through and answer each of them, or get the panel to answer each of them individually. But there were literally hundreds, and so we can't possibly do that. But I do hope we will get through most of the themes, at least, but by the time that we finish at 8:30. However, what we're also going to do is to give you an opportunity to guide the discussion a little bit by voting on which topic you'd most like to see discussed. So on the screen there are the main themes that came out of the questions that you submitted for the webinar. And so we're going to ask you, you're going to have 30 seconds to vote on which one you think is the most important. And so if I could ask Ronald from Redback to start the poll. And so you now have an opportunity to click on one of those boxes and to put your vote in as to which one of those areas you think is the most important to discuss. And clearly our panelists have already foreshadowed several of those and covered many of those topics. And I'm also sure that regardless of which one we choose, we end up with, we will cover all of them in some form or another. But this is your opportunity to tell us a little bit about what you'd most like to hear about. So we've got about 5 seconds to go. If you haven't voted, please do so. Okay, thanks, Ronald. We'll wind it up there. And if I could ask you to put the results up on the screen, that'd be great. And if I'm looking a bit close to the camera, I must apologize, but the writing's very, very small on my screen, and I can't read it unless I get very, very close indeed. So just bear with me. Okay. So we've got a few close run ones, but as far as I can see, the therapeutic approaches is coming in as a clear winner, and I guess that's not entirely surprising. So we will certainly do that. I think all our three speakers touched on some of that stuff, but we'll come back to that in some detail. I'm going to take the, well, my opportunity, given that I'm chairing it, I can decide what order we talk about things in, can't I? So I'd like to talk about things in a slightly more logical order, and I'm not dismissing the therapeutic approaches. We will spend most of our time on that. But I would just like to come back, if I could, to the panel and ask them about this issue, about how somebody gets into treatment in the first place. And I might kick off with you, Matt, if I could, but certainly the others can jump in. You were suggesting perhaps that Chris's reasons for getting into treatment may not necessarily be the appropriate reasons. Can you just talk a little bit more about that and whether or not that might mitigate against a successful outcome?
Well, look, I mean, I think we're accustomed to seeing people who've been brought in by family who are completely disinterested in treatment, particularly young people, and those things, that sort of setting can is always, I think, those sort of situations are worth pursuing clinically, but I guess they're the situations where your outcomes might be affected by the simple fact of the patient's motivation, the individual's motivation. I actually was saying that I think a little bit of a push is sometimes really helpful to get people in the door of treatment. And as Nicole said, that most treatment that we do has some benefit. It's a matter of what dose you can give over what period, about how sustained the benefit is. So I think anything that gets somebody in the door is very helpful. And if there's a subtle push that makes up for perhaps some loss of motivation in the individual, which isn't uncommon, I think that can make for somebody that ends up being engaged for a while. I think when you say, I must say, when you said how do people get into treatment, I was thinking, if you're from Victoria, I don't know the answer to that question, but in other parts of Australia, it's perhaps a bit easier to get into treatment. Actually, how you get in the door and access treatment for many people is a real challenge, and I don't know if we'll answer that in this webinar. But look, I think it.
Presumably, sorry to interrupt, Matthew. Presumably, a lot would come through their GP, and I'm wondering whether you would like to comment or anyone else would like to comment. We hear, we hear a lot about motivational interviewing. Is that something that's effective in terms of engaging people in treatment?
No, look, I think that what GPs can do, and it's a very important topic for me because half of my life has been trying to engage GPs in working in this field and not being scared of the field. And I think GPs are particularly important. Everyone's got one or is probably at least near one. And a lot of their work is in a very small time frame. And because of that has to be brief. And so a small dose of intervention from the GP can have a great benefit. So, yeah, because GPs, whether we like it or not, are underwritten by the taxpayer and are very accessible in this country, I think they are very good starting points for people seeking help.
And presumably, John, that would be the same in currently serving personnel, that they're likely to come through the MO on the base or something like that. Would that be right?
Yeah, exactly right, Mark. And I was actually going to jump in and support Matthew there as well too. Look, fundamentally heavily rely on our GPs, and going back to that whole social connectedness thing, with a lot of people, like the guy in the vignette, Chris, or our other veterans, their main social contacts actually come from their treating health personnel. And so whether they're active duty or whether they're veterans, left the military, the GP, the other people that they see, the other health professionals that they see, all have a massive impact on them. And this is not coercion, but a short, brief intervention from a GP saying, "How you going, mate? How you going with the drinking thing? Are you still on track, or have you fallen off the wagon? Just what's going on?" That's basically sort of a huge part of keeping the motivation going to actually abstain from treatment, or to control drinking, or to do whatever else. And it's also a way for the person to reflect their own, or get that person's behaviour reflected back to them. Now, in this particular vignette, we've got Chris's grandfather saying, look, you need to stop drinking. But what about, what about his GP? What about his psychologist? What about the other people that are in his life saying, geez, Chris, mate, you sure you're not doing a bit too much here? Is it time you had to look at yourself? Is it time you had to think about what you're doing there, mate? That's the motivation to actually engage in doing things. And the big thing that stands out with Chris is, well, the first things I'd be asking is, well, why do you want to stop? What's the point? What are you doing here in the first place? Now, that actually means that Chris has to have a look at himself and go, am I really this ambivalent about engaging in some sort of abstinence or cessation or even just, reduction program? Because until he works out what he actually wants from it, it's really hard for any of us to actually help him. Yeah.
Yeah, absolutely. And I think, depending on how we look at coercion, I think, Matthew, you alluded to this in Chris's case, but certainly our experience in PTSD treatment is that very often it's only because their wife of many years has said, right, that's it, I'm leaving you unless you turn up for treatment. So that's kind of coercion, but it's coercion with a big carrot, I suppose, and so on. Anyway, let's move on. One of the questions that participants have sent in is about the types of drugs that we're seeing. And I wonder if I might throw to Nicole first, but whether any of you have thoughts on the types of drugs that you're seeing. And the particular question actually was about they seem to be seeing an increase in the amount of marijuana use and the feeling that that is reducing the benefits of the other medication they're taking and so on. Is marijuana use a problem in your experience, Nicole, and others?
Well, it's the most commonly used illicit drug in Australia by far. So it is highly likely that we'd see a lot of that. I'm not sure why we would be seeing more people in treatment, particularly now, because the use rates haven't really changed, and I'm not aware of anything particular about cannabis. Not like, people have kind of switched from speed to ice, so we're seeing a lot more problems associated with that. I'm not aware of anything in that area, except for the introduction of synthetic cannabinoids, which cause a lot more problems than cannabis, traditional cannabis. But generally, drug use is flat, but who we see in, again, just back to the harms versus use, it's generally flat over time, but who we see in treatment changes all the time depending on how harmful particular illicit drugs are in the market.
Yeah, you mentioned there about synthetics. One of the things I've heard a lot, and I wonder if it's true, is that although the usage of marijuana hasn't necessarily gone up, the strength of what people are using is much bigger now than it was maybe 20, 30 years ago.
There isn't really much evidence to support that. I think, we've been through probably the 60s and 70s where there was reefer madness and there was hydro in the 80s, and every generation has a strong version of cannabis, and there's not a lot of evidence that it's particularly stronger at the moment. But then it may be that people are tending to use stronger forms of it,
right?
And that's why perhaps we're seeing more in treatment.
Yeah.
Mark,
okay. Please do. Yeah.
Sorry, just to emphasise Nicole's previous point on harm, versus use, and quite a few of my patients use recreational quantities of cannabis, but the majority of harm I see comes from alcohol, and I'd be interested to see what the other clinicians think about it, or what the people in the audience think as well too. But in terms of harm, that's alcohol, and whether it's family or work or other reasons that are driving people to treatment, effectively the majority of harm that I see comes from alcohol abuse.
Yeah, by far.
Yeah, okay, interesting. All right, let's move on, and I haven't forgotten treatment, don't worry, it's still there massively in my head. I'm thinking about, though, the sequencing of treatment, and I guess it's probably true to say that very often, and Nicole alluded to this, but very often people presenting with substance use problems, and I think particularly veterans and serving personnel, also have other problems such as depression and perhaps anxiety and, of course, PTSD. I'm wondering if anyone would like to talk about how we go about sequencing, how we go about thinking about what to treat first. And I guess it perhaps speaks to the whole issue of the role that the drug is, or the alcohol is taking in the person's life in terms of symptom management. But yeah, would you like to, anybody like to take that one about sequencing and how we go about treating comorbidities?
We used to say that, you know, you should treat together or not, you know, one at a time, and don't send people to different places, and all of those things are still true. But I think one thing that I've learned, particularly in the last 10 or 15 years, is that whatever the client presents motivated enough to change, is the thing that you should target first, because we know that if you address the drug use, just the drug use, mental health and physical health tends to improve, and if you target mental health, drug use tends to improve as well. So really, you just take your best shot at whatever you're best at that the client is prepared to work on, I think.
Good. Well, yeah, go on, John.
Sorry, Mark, I was going to echo that as well too. You know, like realistically, all of these sorts of things have to be driven by the person who walks to the door and sits down in front of you. And, you know, again, if it's the substance abuse or misuse that's causing harm, that's one thing. If it's their underlying mental state that's causing harm and causing them to rely on alcohol to sleep or to do whatever else, then that's something else again entirely. And, you know, if you can treat underlying conditions, then again, as Nicole said, the reliance on substances to moderate mood and to reduce distress all tend to improve as well too. And so it goes back to that same sort of thing of what's actually wrong with this person in front of me. You know, why are they relying on substances to change their mood, to help them cope, to get through life or whatever else? That's basically the first way to do it. And then once you've got that motivational, you know, entry, then you can start to pick apart the problems, help them cope, help them find other ways of coping, and then build up, you know, community supports, social supports, occupational supports, etc., and then, you know, go on from there as well.
Yeah, good.
I think if you're not sure where to start, just start anywhere that you feel comfortable starting.
Yeah, I think that sounds like very good advice in the real world. I think it sounds great. Did you want to add anything to that one, Matthew, to that question about sequencing?
Look, I just want to echo what Nicole and John said, and I think we have actually spent a couple of decades trying to grow skills of this divorced couple of mental health and addiction or drug and alcohol. I don't think it's been a huge success, and I think the idea that you do your best with what resources you have available rather than be you know, incredibly competent in every part of drug and alcohol or every part of mental health or every part of dual diagnosis is really a good clinician approach. So I agree with that, and I think, as Nicole was saying, that most of what we do, most mainstream treatments kind of have a benefit, and so rather than you know, trying to have all your staff trained in every field of drug and alcohol and comorbidities, I think having some good staff in either area is probably where we're settling at.
Yeah, and look, it certainly makes a lot of good sense in terms of the that very practical advice about starting where you can and starting where you think you'll have the most success, because that's where the client is at that time. The only thing I might do, I guess, is just add a slight, well, caveat from my perspective, I suppose, as someone who's working a lot with the PTSD end. And my, I think I would say that it's difficult to do some of the trauma-focused kind of stuff, the exposure type work, if the person is going to then go and use alcohol as a way of managing the distress, because we need it to sort of habituate more naturally. But that can be some way down the PTSD treatment way, so I don't in any way disagree with what you're saying there. Yeah. Let's go on then, given that it was the topic that most people wanted to talk about, and see if we can talk a little bit about evidence-based treatment. I know that John alluded to some of the medications, or medications generally, and Nicole also just very briefly mentioned some of them. But I wonder if I could ask one or all of you to talk just in a little bit more detail about what the evidence says are the most effective treatments? And perhaps start with you, Nicole. I know you did suggest that a number of them really come out pretty much the same, but can you just talk us through again those key approaches?
Yeah, so the core practices, psychological practices in the alcohol and drug field are motivational interviewing and some form of cognitive behaviour therapy. In terms of, no one's kind of pitted all the different types of CBT against each other or against other therapies really in any real meaningful sense. But the main treatment that we would use is Marlett and Gordon's relapse prevention model, which is quite at the behavioural end of CBT and less at the cognitive end. And motivational interviewing, which started out just as in the 80s as a reaction to some of those confrontational shaming approaches, diametrically opposed to those. But it now has a really good theory around it and has been extensively researched and tested, and it is effective in getting people to change their drug use and a whole range of other things too.
That's good, isn't it? And a relatively simple intervention, I guess, motivational interviewing. Can I just, presumably, we would often be talking about using those cognitive behavioural interventions in also with medication as well. And I wonder if I could ask Matthew or John to talk a bit more. My very, very limited understanding of the meds is that there are a whole number of them that seem to work in relatively different ways. If we look at naltrexone or acamprosate or antabuse or the benzos or whatever, are they all working in a slightly different kind of way?
Yeah, I mean those ones you listed do work a bit differently. I mean, look, I'm glad we've talked about medication and assisting what is the core treatment, which is usually talking therapy, which Nicole mentioned, is psychotherapeutic approaches with medications, because look, as Nicole said initially, that what I think there is a lot of nihilism both within and outside the medical profession. People working hold script pads and work with people with drug and alcohol use disorders about the effectiveness of medications, and actually so I hear it from colleagues all the time that medications aren't going to work because they continuing to drink alcohol or use other drugs, or they've never worked in the past because in previous experience with this medication, patients always relapse. As Nicole was saying, the actual outcome are about the same as treating high blood cholesterol or high blood pressure or diabetes. I mean, those outcomes aren't perfect, but things like the number of people you've got to treat to get a response, and the percentage of people that do well on these medications compared to placebo it compares really well with other medications that we prescribe. So I think it's very important not to disregard, even though we have a pretty limited toolbox there in terms of medications compared to mood disorders, and other conditions that might present to people that prescribe. The medications we've got and some of the medications we use inventively have got really good outcomes, really good effects. So that's what I'd like to people to remember, that often assisting abstinence or assisting reduction of use with the medication has got very a positive benefit.
And in terms of the range that are available, and I guess it is going to be tailoring it to the individual, but are there any particular ones that you would see as the usual first-line approach in terms of meds?
Look, for alcohol use disorder, there's 3 drugs that are approved in this country, and generally you start with the drugs that our pharmaceutical benefits and therapeutic goods people have deemed are appropriate. So there are some listed indications for those drugs such as disulfiram, acamprosate and naltrexone. And they'd probably be the ones that I would certainly suggest primary care prescribing doctors to start with. But you know, there's another tier of drugs that can be used as a second line. Yeah.
Okay.
So
yeah. Okay. Great. Thanks. I'm interested in all of your comments actually, but I'll throw to John first. I guess the question really is about whether or not, and I think you mentioned, John, that you've got no problem with people having a couple of beers, two beers. I've forgotten it already, but I know the gist of what you're recommending. What about abstinence? How and when do we make the decision about actually this really should be abstinence? And I'm also wondering if you could go on from that and just talk a little bit about how we support people through that process. You know, we've heard over and over again about the risk of relapse. So how do we support people through abstinence? John?
Yeah, look, Mark, really, you know, interesting questions. And then, you know, throwing back to Matthew's brief points there too about, you know, using medications to help maintain reduction or abstinence. Now, abstinence is a hard thing to do for anyone. And it's also a very hard thing to raise to people, you know, in the room in front of you as well too. But again, you know, as Nicole said earlier, what I do is talk to people about the harm, and I talk to them about their level of control. And now, if they cannot physically stop at one drink and they can't stop harming themselves, then abstinence is pretty much the only way for someone like that to go. And you know, the reality of the situation is that every time you drink, you go and make a fool of yourself, or you do something stupid. Then, unfortunately, you can't afford to drink. Now, you know, relapse prevention is probably by far and away the most fundamental part of the whole conversation, because how do we stop people from relapsing? How do we keep them engaged in treatment, keep them productive, and keep them proactive about their own future? That, to me, is actually the biggest challenge, and this is why relying on sort of external activities that people are doing, you know, what sort of, you know, what is their role? What is their purpose in life? What are they actually doing and achieving? Because if you don't have a direction to go in, then most people will wander aimlessly and sooner or later will fall off the bandwagon. So whether it's getting back to study, getting back to work, whether that's paid work or voluntary work, being engaged with the community that you live in some way, shape or form, you know, being a parent or whatever it is, that's the most important thing, because that is what is going to drive the motivation to maintain abstinence, to stop looking like a fool, and to stop ruining your life. And, you know, apart from those sorts of things, I don't know really a lot of other tools to try and keep people engaged, because, you know, a negative doesn't work. You have to be pushing people for a positive outcome, not a negative outcome.
Well, let me ask you about one, well, not necessarily you, John. I'd again like to hear from the whole panel about it. But one of the best known interventions, and I suspect also perhaps one of the most controversial, is Alcoholics Anonymous. Does AA have a role to play during that period of maintaining abstinence over the longer term?
There was some research a couple of years ago. It was undertaken in several states in Australia, just looking at outcomes from treatment and what maintained goals, abstinence or using goals after treatment, and mutual support of some kind was associated with lower levels of relapse. The first thing people think of is AA, but there's a pretty high dropout from those groups, and it's not for everybody, but for people who it is effective for, or who it speaks to, they do quite well in those groups. And as John was saying, it's really about that post-treatment support of some kind, engagement in something meaningful to you, so that you maintain it, and something that is supporting whatever your goals are around drinking and drugging.
Okay. All right. Good. Thanks. No one else want to say anything about Alcoholics Anonymous? And you don't have to. I'm not pushing.
The challenge, I think, with finding evidence of benefit with a group like AA's and the other brother and sister 12-step fellowships is that it's really hard to establish, you know, causality. I think that's the real challenge. There's another dimension of difficulty with AA, because it is, based on anonymity and doesn't tend to get involved in research assertively, perhaps as some of the other organisations might. So I think most of us would say if somebody's doing really well in recovery and finding a mutual support program is helping them, we hopefully most people would really support that and encourage somebody to partake in those sorts of things. I mean, it really makes sense that something that engages you with communicating with a group of like-minded people is going to help you. I mean, it's not rocket science. I think the thing about AA, I'd say, is that they've got the advantage of being big, having meetings every day, several times a day, everywhere, all over the world. So they're hard to compete with in terms of accessibility. But I agree with Nicole. Some people find the 12 steps and tradition a bit repellent, and the culture of AA a bit repellent. But
there are
extraordinarily well.
Sorry to interrupt you, Matt. There are other options as well, like smart recovery, which some people find a little bit more palatable. So, but I think the point is that some kind of post-treatment support is helpful, whether it's 12-step, if you like that kind of thing, or smart recovery, or some kind of peer support or family support. All of those things are associated with lower relapse rates. Only slightly lower relapse rates, but lower relapse rates nonetheless.
Sure. Okay.
I think Mark, just look, it really comes down to the individual in the room and what will work for them. And, it's worth giving it a shot for people, because even though they might not think it would work initially, if they give it a go, it might actually work for them. So unless they've actually tried it, it's really hard to dismiss it out of hand. Some people do really well, some people don't. And the fact is that, again, with the difficulties of maintaining abstinence, and avoiding relapse, you have to pretty much try everything you possibly can, because everything that makes a difference in someone's life has a direct benefit on their life. Avoiding that relapse or reducing the severity of the relapse and those sorts of things just make such a big difference in terms of functional outcome for people. Yeah.
Okay. Good. Very useful. I'd like to just shift the focus a little bit now. One of the topics was about working with underlying trauma and or chronic pain, and I think they're very different, and I think we've talked already really about the sequencing of treatment around substance use and PTSD and trauma and so on. But the chronic pain issue I think is a very interesting one, because I get the impression that we see people who have started to abuse analgesics, I suppose, or have started to abuse a range of prescribed and non-prescribed medication as a way of dealing with chronic pain. And we do have some of our veteran population who've experienced severe injuries, physical injuries, and perhaps might be using analgesics in that way. So I'm wondering if anyone would like to comment on that, whether that is a significant problem and how we might go about it, where the substance use is perhaps being driven by chronic pain. Anyone want to take that one?
Look, Mark, I'd love to start on that, because a large proportion of my patients will come in on a significant range of different medications. And so it's not just opiates, it's benzos as well. And so comorbid benzo and opiate use is contraindicated for a whole bunch of different medical reasons, but they tend to exist hand in hand. And benzos in particular are very, very seductive for people with any sort of trauma history or anything else, because it makes them feel safe. And it's very easy to get reliant on them. In terms of the physical injuries, again, so many of our veterans have chronic physical injuries that they then go down the track of, I need treatment. And so treatment, of course, involves getting rid of the pain. And so that naturally involves the prescription of opiates. Now, getting off these opiates can be really quite tricky, and managing the pain can be really quite tricky as well too. And, a big part of the focus then needs to be on managing the pain, not actually trying to find a fix for it. Because while people get sort of fixated, for lack of a better word, on I have to make the pain go away, you won't actually be able to get them or get them off opiates, let alone reduce their use and those sorts of things as well too. So the comorbid benzo and opiate use is a huge problem, because then of course it's so easy to mix alcohol with it, or cannabis, or whatever else. So definitely a major
I think
issue.
one of the important things way back, when someone first presents with either an injury or PTSD, particularly around chronic pain, the kind of newer thinking is really that it is very neurologically based and not very physically based. In when there's not a particular physical reason for having pain, people still experience chronic pain, and the first line treatment should probably be psychological rather than opiates or any other medication, if that's possible, because it is very easy to get to become dependent on those very powerful drugs, and it's very hard to get off them.
Yeah. Okay. Thanks for that.
I agree.
Go on,
can I just say that? Look, when I said medications work and we shouldn't be afraid of prescribed medications, I didn't mean pain medications. I think the use of pain medications in armed forces people and police and nurses, just many professions where that might have some physicality and persisting pain conditions. The prescribing of opioids and the marketing of these drugs is probably one of the biggest public health disasters of the 21st century and maybe or the 20th century. It's an extraordinarily embarrassing stuff up by the pain sector and by physicians. What have we learnt? We've learnt that the best management of persisting pain is not to look at the scan and prescribe an appropriate dose of narcotic. It's, as Nicole said, this is a condition that's best managed without drugs.
Yeah, I think it's a very important point, Matthew. And of course, we do now have some good evidence-based treatments for chronic pain as well. So, sorry, should be using those. We started 5 minutes late, so I'm going to take an executive decision that we'll run 5 minutes late as well, unless I get an angry message in my message box telling me I'm not allowed to. But we will have to be quick. I just want to touch on one final area, and we will have to be relatively quick. But that is about the cultural stuff around the veteran and military culture that encourages drinking behaviour. And I'd be interested both perhaps from your perspective, John, about whether you think things have changed in terms of the military culture and also whether it's different across perhaps the different services. And the second thing I'd like people to just think about is whether or not the support networks that exist for veterans, and I'm thinking particularly things like the RSL clubs, actually, are sending mixed messages because they make their money out of alcohol. So I'm only going to give you a couple of minutes to address that, but can I just get people to jump in with that one about the cultural pressures generally?
Yeah, look, Mark, I'll kick off. So cultural pressures in the military now aren't anywhere near what they were 15 or 10, 15, 20 years ago. The only data that we really have is the mental health and wellbeing study from 2010. And so looking at Defence Force personnel, and it showed again that drinking was, substance abuse rates, alcohol in particular, were lower in uniformed service personnel than they were in veterans. However, in veterans, the substance rates were higher. Now, again, the obvious conclusion from that is that being in uniform and in the military serves a strong protective mechanism because you have an occupational role to protect. So that's the big thing. The cultural sort of stuff, yeah, yes and no, but maybe it's just an excuse for people who want to drink because there's more access, there's more availability, and it might be more socially acceptable. But blaming that as a reason for dependence or abuse, I'm not so sure about.
Fair enough too. Okay, thank you for that, John. I'd like to ask the others, but I'm afraid that we are sort of running a bit short of time, and it's always the same with these webinars that we could, I think, go on for much, much longer. But the clock is ticking over, and so I do have to wind up reasonably shortly. What I would like to do is just ask each of our panelists whether they have any final comments they'd like to make, any key points, any take-home messages that they'd like to leave the audience with. So can I perhaps ask you first, Matthew, about whether you have any final words?
Look, really that to reiterate the idea that treatment works, that I know we've got a wide audience out there in the webinar, but for clinicians to continue to work with people with comorbidities or substance use disorder. I really think this is a rewarding field, and it's a field that pays dividends in terms of good outcomes. And we're always struggling to maintain a strong and growing workforce in drug and alcohol. It's an unfashionable area to work in. It's a low prestige area, was perceived as a low prestige area. And part of that is because of this nihilism about treatment, and I really think when we discuss these cases or have a case-based discussion, what we don't see is there's often the positive outcomes and the gains that, because we have to pose a lot of these cases as a clinical challenge and problem, and we don't necessarily see the happy endings or the positive outcomes or the benefits of the days of reduced intake that actually we get when people involve themselves in treatment. So that's probably my take-home message.
Yeah, and I like it a lot, Matthew. I think it's great to have that positive look at things. And as you say, I suppose traditionally it hasn't been a particularly a popular area for clinicians to go into, but I think, as you say, they can get some great outcomes. And so if there's any students out there thinking about where they want to take their career, alcohol and drugs, where you got to go. Nicole, some final comments from you?
Well, yeah, I guess I have a similar pitch that that treatment is effective. The main treatments are psychological. I think that if you're not sure, just do something, whatever's within your sphere of expertise or influence, and make sure you follow up with people. But if you do all of those things, we know that treatment is as successful as any other chronic condition. And I think we just have to think about it as a chronic condition and have expectations commensurate with that.
Great. And I do like that philosophy of just do something, do what you can do. I think is really important. And the danger for clinicians of sitting around thinking, oh, I don't really know too much about it, and maybe I shouldn't do this and shouldn't do that. But getting in there and doing something once the person has actually made the effort to come and engage with you, I think is really important. So I'd certainly go along with that. John, any final comments from you?
Yeah, look, just to echo the previous speakers, just have a crack at it, because you can't deal with veterans and not deal with substance abuse in some way, shape or form, regardless of what it is, because, we use drugs to help us cope, and that's coping with distress in whatever form that takes. So everyone is going to be using something. So you do need to have some sort of basic familiarity with it. You don't have to be a complete star. It doesn't have to be a focus of your work, but it's certainly going to be a part of your work. So basically get over yourself and just accept that you're going to have to deal with it would be my short, succinct advice with that. But look, just lastly, I'd like to say, as a veteran myself and as a clinician, I would just like to thank, DVA for putting these sessions on, because they've been incredibly good. And, the previous topics of insomnia, and the anger and irritability stuff coming up, the PTSD, all those sorts of things are fundamental to dealing with veterans. And so it's just fantastic to see this sort of specialist and specialised knowledge coming out into the wider clinical community. That's fantastic. Thank you.
Thank you very much, John. And I endorse entirely what you're saying there. I think it's a great initiative, and I think the numbers that we're getting webinar after webinar to this series of webinars are enormous. I haven't seen the recent number, but we were up around 800 the last time that I looked. So it's very, very impressive. We're obviously talking to a lot of people out there for whom this is important. I'm going to just finish off with some very quick admin kind of stuff. Oh, not that slide. Just bear with me. MHPN organises local networks where clinicians from different disciplines can meet together and get support and share ideas and so on. I think it's a fantastic initiative, particularly for clinicians who are a bit isolated in their private practice. So if you're interested in getting involved in one of those, make a note on the relevant section of the feedback survey, and MHPN will contact you to talk about one in your area, and I'd strongly encourage it. We will be sending out a link in the next week or so to the recommended resources. These are resources recommended by our panelists and also by DVA, and there's some really good stuff there. So that link will be sent out to you fairly shortly. You can access it from the bottom right of the screen, but once this is over, there'll be a link to it. Please complete the feedback survey before you go. It really is important for us to know how to improve these webinars and how to make sure that we're meeting your needs. And my understanding is that you only get your certificate of attendance once you've done the exit survey, so please do that. In the meantime, keep an eye out for the next webinar, which, as I say, is on anger in veterans. I think it'll probably be around late June, early July, and I look forward to talking to as many of you as possible then. In the meantime, thank you very much indeed for your participation and your engagement in the process. It's really been great, and a particularly strong thank you to our 3 panelists for tonight.